Thanks, Sig, and thanks everybody for being here. I appreciate Innovasis for the invite. It's always a great conference. So in terms of overview, some of this is a review, but I think the main rationale for interbody is to enhance fusion rate and success and to protect distal fixation, especially in these cases of larger deformities. There are some other less important factors: sagittal plane correction, coronal planing correction, foraminal decompression, and indirect decompression we talked about. Consideration for full lumbopelvic fixation is really a key aspect. And then Sig already implicated the differences in implant materials and the evolution of implant materials. I put this one picture up. I think it's important to remember where we were. This was 40 years ago, an article by Henry Bowman about the posterior fibular dowel across the sacrum and into the L5 vertebra. And just 40 years ago, we didn't have any instrumentation. So this was kind of state-of-the-art for the time. That procedure worked really well. It's considered the Bowman technique. But things have changed a lot, as we've seen, since those times. So fusion success, why is it so much better going in the front than the back, as everybody has pointed out? Well, number one, greater surface area. Compare the interbody space to the transverse processes. It's a dramatic difference in surface area, and there's far greater osteoprogenitor cells. The biology in the front of the spine is very different than the back of the spine. There's just more cells there. And then there's Wolff's Law. The graft is loaded in compression. We know bone and osteoblasts respond to compressive loading. And the apophyseal ring is crucial for deformity correction. And then, at least if we're doing LT cages, you have the possibility for on-label BMP use. I almost consider BMP in the interbody anteriorly as sort of quote-unquote on-label. Well, protecting distal fixation is also crucial. So here's a patient of mine who I kind of underestimated the forces. So we did an L1 to 5. We had great correction on the table. And then 3 months later, she just bent forward and plowed through her 4 and 5 screws. And so the interbody allows you to protect those distal segments because it blocks flexion. I mean, that's the key. It also blocks lateral bending, and some rotational moments can be reduced, especially if you fix the interbodies. Certainly more levels are better in protecting the distal segments. And as you can see here, we're able to bring her back and do a back-front-back with lordotic cages. These patients are pretty miserable. Here's a similar case. This is a 58-year-old who presented 3 years after an L1 to 5. She plowed her L5 screws, and she developed a spondylolisthesis at 4 or 5. So a similar kind of approach, back-front-back with lordotic interbodies. And it's pretty powerful. We were able just to domino to what she had there. And here you can see her ultimate correction. Obviously, you can protect the S1 fixation with interbodies as well. And I really like 2, sometimes 3 interbodies for that kind of protection. I think it allows you to sometimes obviate the need for pelvic fixation as well. Sagittal plane correction is key. Nowadays, lordotic interbodies, I can remember being trained by John Kostowick. He cut all of his allografts, as Sig alluded to, and now it saves about an hour worth of time. And I can remember him getting pissed off because he didn't cut it to the right angle and have to go back and start over again. But now, standard, you have up to 30 degrees of interbody, and with additive manufacturing or 3D printing, you could customize the degree and even get a 2-plane 3D printed implant if interested. ALL resection is absolutely crucial, and L5S1 is where you're going to get the greatest capacity for your reduction. So focusing your reduction techniques at 5-1 and your corrective techniques at 5-1 is crucial. And in my practice, it's really supplanted the use of PSOs. There's certain cases where I still like a PSO, but you can create a nice harmonious lordotic reconstruction with use of interbodies rather than the use of a PSO. Here's a patient I just saw this week. It's a patient from an outside hospital, had 2-level interbody, and really has a collapsed 5-1 and a kyphotic 2-3. I put this out there. I don't have a slide to follow up because we haven't treated him yet, but I think some may approach this with an L3 PSO. Some may approach this with with posterior distractables like was tried. Some people may approach this from an anterior. My plan would be to go in the back, do a fascicectomies at 5-1 and remove the rods, and then do an A-lift at 5-1, stand them up, and then likely on a second stage do an X-lift at the 2-3 segment and just extend them to the sacrum. Here's a really interesting comparative study looking at interbody versus pedicle subtraction osteotomy, specifically with reference to neurologic injury. And it's important to see the difference in PSO at 15% versus 3%, statistically significant increase in neurologic risk with PSOs. And the problem with the PSOs is they were permanent neurologic injuries, whereas in the O-lifts they all were resolved over time, and there are more alerts with spinal cord monitoring and PSOs. This is a patient of mine, not taken directly, but I think you could apply it to that same paper with a previous Harrington rod that had fractured and flat back syndrome. And so similar technique, back, front, back with lordotic interbodies. These are some of my favorite cases. These patients do great. This is a patient who was a vendor at Orioles Park, and she was able to go back to working and selling lemonade at the park. Interesting also to note that blood loss substantially higher with PSOs. Well, what about indirect decompression? I showed this case last year in a different talk, so forgive me, but I feel like these are elegant procedures. This is a patient with an adolescent idiopathic scoliosis of adulthood with severe foraminal collapse at 4 and 5 on the left side. And a little lateral listhesis at 3-4. Very compliant patient, thin patient, very athletic patient. So staying out of the posterior envelope altogether and just doing standalone anteriors I think is really nice, and he fused incredibly well. What about lytic spinal listhesis? I consider this a deformity operation rather than a degenerative surgery. And you can increase the foraminal volume nicely, not only with distraction of the disc space, but also with reduction of spinal listhesis. I prefer to do this all anterior without any posterior fixation, MIS or otherwise. But the key is preparation of the disc space, doing a radical discectomy all the way out laterally and posteriorly. And I think in compliant patients, these can work really well. I like to park that inner body deep. The deeper you park it, the better foraminal decompression you get. Yeah.
When you follow these patients out for the isthmic, they don't fail because you posteriorly fix it.
No, they do great. Yeah, I think posterior fixation in these, if you have good technique, is overkill. Even in patients who subside a little, they generally are really still satisfied. So I'll have a few patients that might subside, but the degree of decompression of the foramen you get, I think, kind of is greater than you actually need in a lot of these. What about coronal plane correction? This is a 72-year-old male, degen scoli, and this is a guy who's really out of balance in the coronal plane. And so using interbodies in this case, it allows you to restore that coronal plane, also gives you nice correction of the sagittal plane. So he's way out of balance. I'm not going to go through all the numbers for the sake of time, but you could do this laterally, you could do it anteriorly, you could do a PSO. A lot of that just, I think, depends on what your comfort level is. So this is a guy, we did a back, front, back. He was auto-fused at 4-5, and we used a 30-degree lordotic cage at 3-4 and a 15-degree at 5-1 and restored his sagittal plane. His coronal plane going back, sort of partially restored. I would have liked to have gotten a little bit better coronal plane correction. The 3-4 interbody is a little too far to the right if I were to critique my slides there. And then what about T-lifts for deformity? It's less powerful than A-lift. I don't know how many people here feel comfortable taking down the ALL posteriorly. I don't, especially when you're at the level of the great vessels. And this requires, therefore, a really careful selection, and these are challenging decisions for me because I just don't have the same confidence that I'm going to get sagittal plane correction with T-lifts versus A-lift. With an A-lift, if I'm using a 15-degree lordotic, I'm pretty sure I'm going to get 15 degrees. With a T-lift, it's just less predictable. And I think distractable interbodies posteriorly for these socked-in cases, I think it's fool's gold. You just can't get the kind of correction that you want. Here's a patient of mine recently with a slip at 4-5 and 3-4, a little bit of kyphosis at that level. And again, this is sort of degenerative, sort of deformity case, but we're able to restore the sagittal plane, pull 4-5 back and 3-4 back, get a little bit more lordosis. But here, again, going back to this previous case from the outside, I mean, they did distractible interbodies at 3, 4, and 4, 5, and there's zero lordosis at those levels. What are the advantages of the TLIF? It's posterior only, so blood loss, cosmesis, consent, time. You don't have to talk to them about retrograde ejaculation, all the anterior risks, and you get really nice fusion rates. And then in the interest of time, I'm just going to hold off on all these evidence slides. We're at 10 minutes, Sig. So I'm just going to go. The last thing I'll say is just some of my own pearls for TLIFs. I always use monitoring. I distract the contralateral side. I like to do complete facetectomies from pedicle to pedicle, and just a gradual distraction, kerosene to increase the size of the interbody window to see well and protect just the exiting as well as the traversing nerve roots. Thank you.